Hi, in this video, we are going to recap Chapter 4, which is the health record content and documentation. So I want to warn all of you, this is a fairly long chapter, so it might take us a little while to get through. So get comfortable, grab you a drink. Unfortunately, I forgot my bottle of water, but so I might have to get up and grab me a drink in between. But really, welcome. In this video, we are going to recap Chapter 4, which is the health record content and documentation. I'm going to warn all of you, this chapter is a little bit long, so get comfortable or get you a drink of water or some food and hang out while we recap this chapter together. So we're going to get started talking about the evolution of the health record. So the patient health record has evolved as medicine and as medical technology has evolved. Health records have existed as long as there have been a need to communicate information about patient treatment. Health records are maintained by all organizations that deliver healthcare services. Health records are also generated by patients with the increasing use of personal health monitoring devices and the ability for individuals to record and transmit data to their providers. So records vary depending on the type of facility. Although format and content of the health record may differ among healthcare settings, all providers of care must maintain information to meet the patient care needs and to comply with relevant laws, standards, and regulations. So a variety of factors influence what's included in the health record and how it is formatted. So meaningful use incentives also drive the content in the format of the health record as providers are required to collect and transmit certain data elements electronically. So some other factors that may influence health record content is the provider's preference, the information required to provide specific care, and then again, those data sets that require certain data elements. Okay, so health records provide proof of what has been done for the patient. I know all of you are familiar with the term or slogan, if it isn't documented, it didn't happen. So as the complexity of care has evolved, so has the need for improved documentation. Standards for record documentation and maintenance have been established and are refined and revised constantly. These standards and regulations have a major impact on what is documented in the health record. The following includes an overview of the common sources of documentation and maintenance standards for the health record. So we have the American College of Surgeons, ACS. They provided the initial standardizing health records when it developed minimum standards for hospitals in the early 20th century. The ACS minimum standard of 1917 included specific requirements for maintaining patient health records. Then we have the Joint Commission, or TJC. That was, or they are, the successor of to the ACS in the area of standards. So the Joint Commission assumed responsibility for the accreditation process in 1952. It was a joint effort with the ACS, American College of Physicians, American Medical Association, and the American Hospital Association. The major source of the information about the hospital or the healthcare facility is the patient record. So Joint Commission surveyors routinely review the health record of current patients to obtain knowledge about the healthcare facility's performance and their overall process of care. So then let's talk about the Medicare conditions of participation. So the Centers for Medicare and Medicaid Services, also known as CMS, is the division of the Federal Department of Health and Human Services responsible for developing and enforcing regulations regarding the participation of healthcare providers in the Medicare program. So the regulations for the health record content and documentation were originally established in the conditions of participation guidelines and regulations under which facilities are allowed to participate in Medicare and Medicaid programs. So, as health record documentation became increasingly important, CMS began to focus on reviewing it for medical necessity and compliance with decision making rules established by the federal government. So then let's look at some state licensure requirements. So every state has licensure regulations that healthcare facilities must meet in order to operate. So licensure regulations may include very specific requirements. I'm sorry, I just had a thought. I'm not sure that I'm sharing my screen. So all of you may not be seeing this. Well, I was just following along with the PowerPoint. So I will go back and watch this video to see whether or not the presentation was being featured in the beginning. If not, I will record it, and I deeply apologize for that. We're only a couple slides in though. So we're talking about state licensure, right? So let's see, after state licensure, internal organizational standards, including bylaws, laws, and regulations. So bylaws, rules, and regulations are developed by the medical staff and approved by the Board of Trustees or the governing body in the healthcare facility. So bylaws outline the content of healthcare records. It identifies the exact personnel who could enter information into the health record, and it may restate applicable Joint Commission and CMS requirements. So bylaws also describe the time limits for completing patient health records. So external surveyors review the bylaws to ensure that the healthcare facilities abide by their own established rules and regulations, and that the bylaws are in agreement with current standards and regulations. So it's important that the HIM professional know the medical staff bylaws, Joint Commission standards, the CMS conditions of participation, and state statutes and other facility licensure requirements regarding the quality and timely completion of medical records. I want to stress the fact that all of you are taking a national exam. So as much as we're going to talk about facility guidelines and state guidelines, I need you to understand that we are to know and understand best practice and national guidelines. Okay, because our test is not going to be specific to our state. Okay, so be sure to keep that in mind. So functions of the health record. The health record must outline and justify the patient's treatment, support the diagnosis for the patient's condition, describe the patient's progress and response to medications and services, while explaining the outcome of the care provided. So the health record promotes continuity of care among providers who treat the patient by documenting all the activities that revolve around the patient. So to providers, the health record is valuable as the principal source of information in determining care for the patient. It is valuable as the primary source of information in determining reimbursement for care. The primary functions of the health record are as follows. So you want to make sure it meets the ongoing care in treatment of the individual patient or outlines the ongoing care and treatment of the individual patient, clinical decision making and communication, reimbursement, including for meaningful use, the evaluation of the quality and efficacy of care, medical research and education, operational management, and then as well as for legal purposes. So responsibility for the quality of documentation. Ensuring data accuracy of the health record content is one of the primary responsibilities of the HIM professional. HIM professionals must lead the effort in healthcare organizations to ensure the availability of quality health information. So, integrity of health information is one of the biggest challenges to health record quality. The copy and paste functionality occurs when the provider copies a note from a previous patient encounter, either onto the same health record or onto the record of another patient. So, organizational policies should be established addressing the copy and paste functionality for the health record, and making corrections and amendments to the health record has occurred in paper and electronic formats, and it's not a new issue for health records. However, EHRs complicate the process of making corrections in the health record. And we're going to talk a little bit more about this throughout the chapter. But the HIM professional must ensure that the original entry in the health record is preserved when changes are made to the health record. So many systems allow various mechanisms for correcting of entries in the health record. And the HIM professional must be involved in the process of how these functions are enabled and how they're monitored. Patient identity management is a huge issue in today's connected environment. Ensuring that the patient or the right patient is connected with the right information relies on accurate patient identity management. The provider of care is responsible for ensuring that the entries made to the record are of high quality. So, although the facility's medical staff bylaws establish the rules and regulations for health record content, the individual care providers are ultimately responsible for the quality of entries that they make and that they authenticate. Okay, so content of the health record. All health records contain information that can be classified into two broad categories: administrative and demographic data or clinical data. So all health record entries must be legible, complete, dated, and authenticated according to the healthcare organization policies. Administrative and demographic information is generally found in the front of the medical record, or the face sheet as we call it. That's when you have paper records, or on the login screen or the dashboard in the EHR. The information entered provides data that identify the patient and the data related to the payment and reimbursement and other operational needs for the healthcare facility. So the demographic information, it includes some basic facts about the patient. So their name, their address, their telephone number, their date of birth, next of kin, and other identifiable information specific to that patient. A unique identifier is assigned to each health record, which is often called the medical record number. And that's what facilities use to as a unique identifier to ensure that all of the information about the patient is entered in the correct record and that the correct record is accessed when a query is entered into the computer system. And when I say query, I'm referring to when we type in that patient's name, that we're going to get the right information, or we type in that date of birth or that social or that medical record number, those elements that we're going to get the right information. So demographic information helps specifically identify the patient and can be aggregated from many patients to provide statistical information that's vital for planning, research, general healthcare statistics, and other needs. So your consent to treat through the consent process is the patient agreeing to undergo the treatment and procedures to be performed by the practitioners. So a general consent is often a part of the admission or intake process into the healthcare facility and can allow the facility to provide routine care. So the consent to use or disclose protected health record information. Under HIPAA, at the time of admission to the facility or prior to the treatment by the provider, patients must be informed about the use of individually identifiable health information. The notice of privacy practice must explain and give examples of the uses of the patient health information for treatment, payment, and healthcare operations. Remember that TPO, okay? And then as well as other disclosures and purposes for established in the regulation. So it also outlines how the information will be used for marketing purposes. But the notice of privacy practice, allow me to say this really quick, is going to be posted at every registration area in the facility. So be sure to tour your facility and look around for those notice of privacy practice and read them because though we're HIM professional, at times we're also patients. So we have to understand our rights in general. So advanced directives is another form of content in the health record. So your advance directive is a written document such as a living will that states that the patient's preference for care in the event that the patient's condition prevents him or her from making medical decisions, okay? It can be in the form of a durable power of attorney for healthcare, in which the patient names another person to make medical decisions on his or her behalf in the event that he or her is incapacitated. Okay, so when the patient has a written advance directive, its existence must be noted in the health record. Patients must be informed that they have the right to have an advance directive. So acknowledgement of patients' rights of information. So CMS requires that Medicare patients be informed of their rights, including the right to know who's treating them, the right to confidentiality, the right to determine what visitors the patient wants to have, and the right to be informed about their treatment. The patient's rights statement must also explain treatment and to participate in their own care planning and to be safe from abuse. The patient must sign a statement that these rights have been explained to them, and the signed statement must be a part of the health record. So you might also see a properties and valuables list located in the medical record. And although the facilities encourage patients to leave like their jewelries and other valuables at home, patients will also often come with jewelry and dentures and eyeglasses and hearing aids and other personal artifacts. So patients may be asked to list these items in a release of responsibility form, which is going to release or absolve the facility from the responsibility of loss or damage to their personal property. So this form also becomes a part of the patient health record. Okay, so content of the health record, we talked already about clinical data but really quick, the clinical data includes information related to the patient's condition, the course of their treatment, and their overall progress. The patient health record includes mainly clinical data, right? So let's talk about the H&P. The medical history is a summary of the patient's illness from his or her point of view. Its purpose is to allow the patient his or her authorized representative to give the practitioner as much background information about the patient's illness as possible. Documentation guidelines for histories and physicals and medical decision making published by the CMS affect physician reimbursement. Okay, we're going to talk a little bit more about that throughout the chapter or really throughout this course because these are key things that I need you to remember for your exam. Okay, so the medical history has several components. You have your chief complaint, your CC, your present illness or history of present illness, HPI, your past medical history, you have social and personal history, the family medical history, and then your review of symptoms. So the physical history is the actual comprehensive assessment of the patient's physical condition through the exam and inspection of the patient's body done by the practitioner. So at the end of the physical exam, the patient or the document should include the impression, which is the list of patient problems based on the information obtained. The physical exam is conducted by observing the patient, palpating or touching them, tapping on their thoracic or abdominal cavities, listening to their breath and heart sound, taking their blood pressure. So the comprehensive physical exam, each body system of the patient is examined thoroughly. The facility must have a policy that establishes a time frame for completing that history and physical. So the CMS conditions of participation requires that the history and physical exam be completed no more than 30 days before. Okay, no more than 30 days before or 24 hours after admission, and the report must be placed on the record within 24 hours after admission. So the Joint Commission requires that the H&P be recorded and made part of the patient record prior to any operative procedure. Okay, so the HIM professional is responsible for ensuring that the most stringent time requirements are followed so that the facility is in compliance with state and federal laws, as well as any regulations, licensure standards, the conditions of participation, and accreditation requirements based on their facility. Okay. So, and you'll notice as we talk through some of these that we typically go with the most stringent regardless. Like if we're talking about record retention, destruction, whichever law is most stringent, whether that be state law or federal law, that's going to be the law that we go with, okay? Or the policy that we follow. Okay, so diagnostic and therapeutic orders. So what can I say about those? Physicians or other credentialed practitioners generate orders with a direct healthcare team. So your orders may be for treatment, ancillary medical services, lab tests, radiological procedures, medications, devices, restraints, or seclusions. So orders change according to the patient's needs and their responses to previous treatment. So orders for tests and services must demonstrate the medical necessity and explain the reason for the order. This explanation is required because payers, they may not reimburse the facility if the reason for the test or treatment isn't properly documented. Okay, so the legibility of the orders is important to ensure that they are clearly understood by the personnel who must carry them out. So some facilities, they use the computerized physician order entry, that's CPOE, for providers to directly enter their orders. The CPOE systems allow practitioners to enter orders directly into the clinical information systems. So the orders must be written by a physician or a credentialed practitioner or verbally communicated to persons qualified and authorized to receive and record verbal orders either in person or on the telephone. So the time the order was given should be recorded in the health record. Orders must be dated and authenticated manually or electronically by the treating practitioner responsible for the patient's care who gave the orders. So there's some like special type of orders. So you have like certain categories of medications such as narcotics or sedatives that have automatic time limits or a stop order is what we call them. This means that the medication will be discontinued unless the practitioner gives a specific order to continue the medication. Okay, so this method prevents patients from receiving drugs for a longer period of time than what is necessary. Okay, so then you think of like your DNR, your do not resuscitate. That order must contain certain documentation that the decision to withhold resuscitative services was discussed with the decision, when the decision was made, and who participated in the decision. You know, was this the patient? Were they aware, alert at the time? Was this a patient representative? So this discussion is also often documented in the progress notes. So the order for seclusions and restraints, which like includes drugs, must comply with the facility's policies and CMS regulations. Also state laws and Joint Commission standards. These should never be standing or ordered or like need orders. Instead, they must be ordered only when necessary to protect the patient or other people from harm or injury. Okay, I hope that makes sense. So the discharge orders, your discharge orders for hospital patients must be in writing and can only be issued by a physician. So when a patient leaves against medical advice, this fact should be noted in lieu of a discharge order because the patient was not actually discharged. Okay. So in case or in the case of death, some facilities require that the discharge to morgue order be written. All right, so some clinical observations. I briefly mentioned progress notes. There's also your MAR, your medication administration records. You have lab, radiology reports, your op reports, your autopsy reports. That's if, an autopsy was done. If the patient expired and they donated their organs, then you have your organ transplant report. And then if it's an OB patient, you're gonna have those obstetrical reports. So the content of the health record. Again, there should always be a conclusion at the end of care or when care is terminated. So your discharge summary, your discharge order, or your discharge plan. So the external records are sometimes filed within the health record, and that needs to be determined. If patient bring like their personal health records with them, are we going to scan those? Typically, in the facilities that I've worked at, we've scanned them, we've put a barcode on them that says external health records. And then also think about social media or electronic communications. For example, if that patient and that provider were emailing, are you going to make those email exchanges a part of that health record or that external record? So there's going to also be specialized content as needed. So, for example, not everybody comes through the ER, right? But when they do, there will be ER records. There may be ambulatory, there may be behavioral health or home health or hospice, depending on whether or not that type of treatment have taken place. The same goes for rehab or long-term care. Not every patient has that type of services, but if they do expect that type of record. So the format of the health record, you have source-oriented health records, and then you have problem-oriented health record. So again, this is the way that the record is structured or formatted. Is it based on that problem? Is it integrated? Is it a little bit of both? Typically, the most common format is the integrated health format. So management of the health record content. So in this next unit or in these next few slides, we're going to discuss several areas of HIM or that several areas of HIM that the HIM professional is responsible for that results in the complete and accurate health record. So transcription. So completion of the health record is greatly enhanced by the sophisticated dictation and transcription methods and equipment in use today. Physicians and other providers first dictate the necessary reports, including but not limited to history and physicals, op reports, discharge summaries, consults, progress notes, etc. The dictated report is then just transcribed to produce a final printed output that can be filed or scanned into the EHR or cold fed into the electronic system or directly transcribed into the EHR to become a part of the legal health record. So components of the transcription system, there's a digital dictation, which is the process by which the voice sounds are recorded and converted into a digital format. If you're not familiar with the transcription process, the physician or provider begins the process using a telephone, a microphone attached to a PC, or a hands-free device. So the dictator typically speaks and the dictation is transmitted to a computer that digitizes the voice, okay? So after the voice sounds have been digitized, the dictation is accessed by a transcriptionist who transcribes the report by listening to the recording. And then converting it to a typed input. So when purchasing or upgrading a dictation, or a transcription system, the HIM professional must be aware of the long range consequences of this important decision. So what does that mean? What am I saying? So the equipment vendors can provide a wealth of information based on their experience working at different facilities. However, transcription may be centralized or decentralized. So in a decentralized system, pathology, radiology, and other departments, in addition to HIM, may have their own dedicated transcriptionists. So the effectiveness and the efficiency of the transcription services are judged primarily by the turnaround time and the accuracy in typing the dictation. So abstracting. Abstracting is the process of reviewing the patient record and collecting data elements, usually in an electronic database. The purpose of abstracting is to make information from the patient record readily available for internal and external needs. Okay, so whether that be for registries, public reporting, or research. So in a facility with paper-based and hybrid health records, there's typically administrative systems for registration, coding, billing, and some clinical systems with electronic processes that require data input through an abstracting process. So incomplete record control. So health records must be complete in order to provide all of the information that's necessary for patient care, billing, and reimbursement. The HIM department must verify that all of the paper records are received from the nursing floor, including records from any previous admissions that were sent directly to the nursing unit. So HIM professionals must then conduct a quantitative, that's what we're going to talk about here, a quantitative analysis, right? You could do a quantitative or a qualitative analysis to ensure that documentation for the patient's stay is sufficient. So what's a quantitative analysis, you ask? It's often called a discharge analysis, and it's a review of the health record for completeness and accuracy. So it is generally conducted retrospectively, which at the conclusion of treatment, once the patient has been discharged. The quantitative analysis may also be done while the patient is in-house, okay? So in that case, that's referred to as a concurrent analysis, okay? So concurrent, meaning at the same time or while the patient is still in the facility. A benefit of this type of review is that the HIM professional is on the floor and can monitor the record completion. They can communicate mission items or remind the physicians to complete their documentation if that they notice the documentation is unavailable. So are you familiar with the universal chart order? So one component of the discharge process is to assemble the record, which is arranging the forms in the paper-based medical record in a standard and permanent sequence for filing purposes. So this process should allow anyone to quickly locate forms as long as they're in the correct order or in the correct place. So are you familiar with the correct way to correct or amend a document? In paper records, the provider should, or when doing so in a paper record, the provider should draw a single line through the error, add a note explaining the error, initial, and date the error with the date it was discovered, and then enter the correct information in chronological order. So for electronic entries, a procedure should be followed that explains how to correct errors and enter an addenda. So if you're not familiar with that policy, I suggest that you find it and become familiar with it, because that's going to help you better understand this process. Okay, so qualitative analysis. In qualitative analysis, HIM personnel carefully review the quality and the adequacy of the record documentation and ensure that it's in accordance with policies, rules, and regulations. So qualitative analysis is a more in-depth review instead of quantitative. So qualitative is a more in-depth review, or it is more in-depth, than quantitative. That's what I'm trying to say. Although the process may somewhat overlap depending on the facility. So when a qualitative analysis is done while the patient is in the facility or under active treatment, it's called an open record review, an ongoing record review, or a continuous record review. So qualitative review is also performed on closed records, which are the records of discharged patients, right? So closed record review means that the qualitative review is done retrospectively at the end of treatment. All right, I feel like I'm going so fast, only because we've been talking, or I've been talking for about almost 40 minutes now. And I still feel like we have so much to cover in this chapter. But as I said to you, buckle up, we're almost done. So authentication of health records. What can I say here? Authentication of health record entries. Okay, so authentication, it means to provide authorship. And this can be done in several ways. Signatures that are like wet, we call them wet signatures, right? Signatures that are handwritten in ink are the most common method for signing paper-based records. So TJC allows rubber stamp signatures when there's a statement verifying that the physician is the only one who will use and maintain control of the stamp. But please note that many facilities no longer allow the use of rubber stamps, or they limit its use to certain circumstances. So what's the policy at your facility? So the HIM professional administration and the medical staff must develop medical record completion policies and procedures to and include them in the medical staff bylaws. So although the facility's governing body has the overall responsibility for patient care, responsibility for the delivery and documentation of patient care is delegated to the medical staff. So management of incomplete records. So with the hybrid health record system, the paper-based portion of the record may be scanned at discharge into the HIS, and providers are allowed to electronically authenticate them, right? So CMS, other accrediting bodies and state licensure standards require that the health record be completed in a timely manner. So what's a timely manner? Okay, well, the clock begins running out when the patient is discharged, when they die, or when treatment is terminated. So healthcare facility policies and medical record bylaws must define when incomplete or deficient records become delinquent. Typically, it's 30 days, but check with your facility. Okay, so the management and designs of forms used in the healthcare environment is a concern of all providers because well-designed forms and electronic screens can facilitate the documentation of care. Forms within the paper record must be developed and approved in a careful, systematic process that ensure that the facility standards are compatible with imaging and microfilming systems and do not duplicate information on existing forms. So AHIMA provides a great checklist on recommendations for hospitals and specifically for HIM during downtime related to the emergency mode of operation plannings that's also required for HIPAA elements. So I'm not sure if the forms department is a part of HIM where you are, but in some cases it is. And if it's not, I would figure out who in HIM is responsible for representing HIM on the forms committee. So, okay, so one of the goals of this process is to prevent staff from changing or designing forms that duplicate existing forms or that could be combined into other forms or template. So we want to make sure that there are some form controlled guidelines in place. Okay, so what I mean by that is develop forms according to established guidelines, whether you have specific fonts, specific sizes, certain things such as, first, last name, medical record number, FIN number, it needs to be consistent on every single form. We need to control the printing and use of paper forms and integration of new screen designs or electronic templates. And then guide providers in designing forms and templates according to the guidelines, right? Prevent staff from changing or designing forms that duplicate existing forms, as I mentioned before. So I used to sit on a forms committee, and I used to actually design forms also. And whenever we would create a new form or update a form, I would go to the units and pull the old forms, because sometimes people would hoard them, they would stash them, they would have extra copies, especially in lieu of downtime. So you would have to try and find all of those forms, get rid of them, and put out the new version. So not an easy process to manage, let me tell you. Okay, so health record organizations need policies covering the distribution and storage of health records to ensure that the records can be located in the health record quickly when they're needed for patient care and other uses. So the quality of patient care, as well as the image and reputation of HIM department, may depend on the speed in which the patient health information can be retrieved. So as discussed earlier, the health record is created when the patient is first admitted into the healthcare facility, right? So every patient is assigned a unique identifier, and then the health record is initiated with the collection of admissions, data, or registration information. So most healthcare facilities use a record identification system that assigns a numeric identifier to each patient. So most large facilities use a unit numbering system, which means that the patient is assigned a number during the first encounter for care and keeps it for all subsequent encounters. So the number may be assigned automatically. So another process is a serial unit numbering system. And that process, the patient is issued a different number for each admission or for each encounter. We like to call that the encounter number. So for each encounter, and then the records of the past episodes of care are brought forward and filed under the last number issued. So small facilities, such as physician offices and clinics, they use alphabetic filing typically, while large facilities use numeric filing. So in a straight numeric filing systems, records are filed in a numerical order according to the number assigned. The shortcomings of a straight numerical finding or filing is that most of the file activity, like where the most recent numbers have been assigned, since records have like recent hospitalizations or visits, are the one that's in the most use. So then another option is terminal digit filing. In a terminal digit filing system, records are filed according to a three-part number, right? Made up of two-digit pairs. So like 2, 4, 6, right? So you have two sets or three sets of two numbers, excuse me. The pairs range from 00 to 99. And the last two digits, right? So I said 2, 4, 6. So the last two digits are the primary numbers. So we're looking at the last two, then we're looking at the middle two, then we're looking at the top two. So as the healthcare delivery systems become more connected, as I mentioned before, correctly identifying patients and linking patients is more important and has elevated the role of the HIM professional in patient identity management. All right, so the Master Patient Index, also known as MPI, Master Name Index, or Enterprise-Wide Master Person or Patient Index. So the Master Patient Index is a permanent database, including patient identifiable data for every patient ever admitted to or treated by the facility. So even though patients or records may be destroyed after the legal retention periods have been met, the information contained in the NPI must be kept permanently. So the challenge for facilities is to maintain a correct and current NPI, that each patient has a unique identifier. So duplication and overlays are major problems. So an overlap, let's talk about an overlap. An overlap occurs when a patient has more than one medical record assigned across more than one database. Okay. And then an overlay occurs when one patient record is overwritten with data from another patient's record. I've seen this before, commonly with babies or twins specifically, where you have like twin B or twin A, information is overlaid by twin, by the other twin, because the person who combined the record didn't realize they were twins, or saw the same last name, same date of birth, same mom's name, and thought it was just one baby. Okay, so the health record life cycle, really much, pretty much it ensures the accurate patient matching in the health information exchange and sharing patient records with other facilities. So some content of the master patient index is going to be like the name, the date of birth, the address, the medical record number, the billing number, the name of the physician, the dates of admission and discharge, the disposition, or discharge at the conclusion of care. If the patient died, the date of death, the time of death, the marital status, the gender, the race, as well as an emergency contact. So health record storage and retrieval. So storage is the application of efficient procedures for use of physical filing equipment and storage media to keep records secure and available to those providers or personnel authorized to access them. So planning for health record storage is a major responsibility for the HIM professional, because records can take up a ton of space, and space is expensive. So filing equipment vendors are the HIM professionals' best resources in planning for a filing area that makes the best use of the available space. So when developing a retention schedule, the program must consider, or the department must consider, how health records are maintained, that inactive records are maintained, that record retention is cost effective in terms of storage space, equipment, and personnel, and that a formal destruction process is in place, and that the record retention periods are clearly established. So the last aspect of this chapter really just talks about the elements to consider in the preservation of records. So you always want to make sure that you consider the accreditation and legal health record retention requirements for ancillary materials, because that might differ, destruction and transfer of health records, development of retention program, or the development of the retention program, use of microfilming, microfiching, or optimal scanning, medical methods and records of destruction, destroying unnecessary records, right? How do you handle that? And then destroying or dealing with any outdated media. Like I just mentioned microfiche, right? I have a local hospital who still have their microfiche from the early 1900s, but not every hospital would want to keep those. So when it's time to destroy them, you have to outline a process. How are you going to deal with that type of media? So I hope that this was helpful. I know I said this was a lot. We covered a lot in this summary, but if you have questions, be sure to drop your questions below in the Q&A form, and I will get to them as soon as I have a chance. Thank you for listening to this summary of Chapter 4.